Hi, this is Eric Prystowsky for another segment of EP on EP, and it's a delight to have a guy with me who I've known since the early part of his career, Dr. John Piccini, who's at Duke University and is on staff there, and has had enormous experience with clinical trials, smart as the dickens, and none of that matters other than smart as the dickens right now, John, because what I'd like to do today is first welcome you to the show and discuss a case. So, are you good with that?
Sounds great.
All right.
Happy to be here.
Thank you, John. So, this whole area of CRT has become just a quagmire for clinicians, and I'll tell you why, because I'm going to present you the case. Just tell me what you do, realizing there may not be a randomized trial. I know how many randomized trials you've been involved in, but I think we both agree most of medicine isn't directed by an RCT. So, you're going to find out with this case. It's a lovely patient of mine who's 67 now. This is a real case that I had to deal with this just a few months ago. I inherited him, many years ago. He had had an AV node reentry ablation elsewhere and unfortunately got heart block, so a pacemaker was put in. Was not a happy guy. He came to see me and I took over his care. Years went by, he was fine, and then his EF fell to 30%. Back then I made a decision to put in a CRT-D, okay? It's about 7 or 7.5 years later now, John. His EF had improved and has stayed stable at about 50 to 55%. And guess what? He has come to replacement indication. So you're my consult. CRT-D, CRT-P, any data? Talk to me.
Yeah, no, so this seems like this question comes up all the time. I think the first thing about this case is it reminds us that a lot of the procedures we do have long-term implications for patients, and so we do a lot of lead management at our center, so this frequently comes up. I think that with a pacing-induced myopathy, a key thing I think is further risk stratification, and you said his EF recovered with CRT, so it sounds like he's had a good response, and I assume he's not having non-sustained events on his device.
That's a very good point. I bring that up. No, it's been clean as a whistle.
And it sounds like he's very functional and active by your description.
No symptoms at all.
Yeah, so I think this is a case where continued cardiac resynchronization is appropriate, and if he were my patient, I would recommend he receive a CRT-P. But I guess the caveat would be that, so I trained at Hopkins, so everyone brings up William Osler, and William Osler always says, well, listen to the patient, and the patient will tell you the diagnosis. I think the other aspect of this, as you said at Western AF, shared decision-making, what is that? It's called being a doctor. Right. I think it's really important to go over the risks and the benefits with the patient. And, often they have a strong preference. Well, I'm not willing to take any risk, or, no, I've done really well. I think I don't really want to defibrillate on my re-implant. So I think CRT-P would be a great choice for this patient, but I also think it's important to engage the patient.
And I'm glad you brought that up. And you're right. We did discuss shared decision-making at a meeting you were at recently. I don't mean to knock it as a concept. I don't at all. I just think any good doctor who's been practicing a high brand of medicine for their career has shared decision-making with their patients. We're not God. You're supposed to, right, tell them the goods and the bads and be a part of the discussion. That's why my hang-up with it. I don't like the fact you've put a new name on a concept that Sir William Osler taught everybody how to do. I'm also a big fan of Sir William Osler. Don't forget my father trained with Helen Tausig at Johns Hopkins, so I have a connection like you do, but not quite as strong. So let's talk to me about, I will tell you, we had that discussion. He asked me some questions I couldn't answer. I was curious to get your input, like, well, what is my risk, Dr. P? What is my risk? I told them, based on the knowledge I had of some literature, that it was probably no more than maybe a 1 or 2% possible sudden death and mortality over several years. I don't know if that's the right number, but I made it low because I think it's low, but I don't have that exact number.
Yeah, so I think you've seen a lot of these papers that come into the Journal of Cardiovascular Electrophysiology. The numbers are really low. I think it's always hard to interpret them because they are observational data, and usually the studies, as well-intentioned as the authors are, the patients they're looking at are usually very heterogeneous, so you don't know who was having non-sustained VT, who wasn't, who had an elevated BNP, who didn't. I think the risk is very low, particularly in someone who's had pacing-induced myopathy and has never had, de novo idiopathic non-ischemic cardiomyopathy or ischemic cardiomyopathy. And I think that sure, there are patients who can have an acute coronary syndrome later and have ventricular fibrillation, but the risk of that I think is very low. And I think, you know, the net clinical benefit for your patient probably does weigh in favor of downgrading to a CRT-P device.
Well, he'll be glad to know when I tell him that another Dookie, who prefers to be a Notre Dame, I get it, but another Dookie, I'm going to give you that whether you like it or not, has agreed with what he decided, because he did go CRT-P. I'm going to take a moment though to go beyond this. So that was kind of a little easier than what I'm going to ask you now, and realize nobody has the answer here. So I just want to get your thoughts on it. No data out there prospectively, but let's take a patient now. And we know the Danish data. We know these data that have come out looking at scar and not scar. So I'm going to give you a setup. Patient comes to see John, and it's I won't even make it too easy. I'm not going to make it a woman. I'll make it a man who's got a recent cardiomyopathy, a few weeks old or something. You decided to go do all your good drug therapy, and after 3 months, he still has class 2 heart failure. He has a left bundle, 160 milliseconds. He has no scars that you can tell from a CMR that you've done. And he still meets ICD criteria, theoretically. But you could also argue CRT-P, right, versus CRT-D. What are your thoughts? I mean, I understand there's no hard data. What are your thoughts?
So we have someone who's been treated medically with a left bundle, and now they have an EF that's borderline 30 to 35%.
Yeah, right.
And how old is the patient?
Mid-50s?
Mid-50s, and does he have any other major medical illnesses?
No.
I think this one's a really hard one, and I think a lot of us have expressed a lot of anxiety over Danish, and I think sometimes it's been overinterpreted and other times underinterpreted. But in someone in their 50s who is otherwise healthy and not, you know, being able to definitively state it's all due to the left bundle, I still think that patient benefits from a defibrillator. And I think when you look at the subgroup analyses of Danish, which are always challenging to interpret because that's not how the study's powered, the younger patients really seem to derive a benefit. So that's my answer today. Maybe a year from now we'll have even more data about what we see in cardiac MRI and its prognostic findings. And I think that patient probably would respond and very likely would have a high EF later, but I still think that there'd be good rationale to give that patient a high voltage device.
Yeah, I don't know the answer to that, so I was curious to get your input. I will tell you this though, because of my own experience, I've been looking at CMR for years because I've been into there was a very, very good editorial I read when I was in the early phases of my career called Better Dead Than Red. And it talked about, it was from a famous pathologist, it talked about people who had MI. If you have a through and through infarct, no scarring, one of these incomplete, and the concept you have a scar without a bunch of live tissue in between, you're far less likely to die than if you have one of these incomplete and with a lot of tissue, and we know that's true now because you set up re-entry, right? I mean, you're really a classic case. So I've always been interested in this scar issue, so I've been tracking that carefully, and I've actually been using it. So I'm sort of where you are, but I have to tell you, I'm starting to have a different discussion with the patients. I'm not going to call it shared decision making. I'm going to call it being an O'Slarian doctor. I get the MRI. And I just have an honest discussion with them. That's why I asked you that. And I say, look, I'm happy to give you either one. I will tell you there are data that suggest you're going to do pretty darn well if I give you a CRT-P. This is not 100%, 0%. I'm starting to have that discussion, and I tell them I'm happy to give you either one. And it's been mixed. There are definitely people who said, thank you very much. I'd like the defibrillator, and I do it. There have been a few who said, if the risk is that low, I think I'm fine to go with the P. So I think we need a trial, wouldn't you agree, to answer this? It's an important question.
Yeah, I think we're both highlighting how much we don't know. For example, in atrial fibrillation-associated tachymiopathy, those patients recover when you restore sinus rhythm, but now some of the data suggests that in longer-term follow-up, some of them experiences recurrence or maybe progression of what was initially a subclinical cardiomyopathy. I think it's an incredibly important area for us to learn more. If I may be so bold as your guest, there's a question I've been dying to ask you, and
is it personal or professional?
No, it's professional.
Okay, I'm good.
Your patient that you inherited, if you or I were to encounter a patient today, relatively young, who gets iatrogenic heart block, Would you go ahead and put a His bundle pacer in that patient and try and avoid the problems of RV dyssynchrony and potential pacing myopathy, or do you think we still need more data before we enact that as a general pacing strategy?
That's about as hot a topic as out there, right? So I'll give you the gray-haired response. The answer is no. I wouldn't, and it's not because I disagree with the physiology. We haven't engaged into that as much as I'd like. I brought in some people to speak to our core about it. A couple of the guys are thinking about maybe they want to do it. I don't know 10 years, 15 years. I would say no right now, but I know with a qualified, like you said, that I'm totally open-minded on this one because the physiology is fascinating. Ken Ellenbogen is, I've had him lecture at some of my courses, and he's shown some wonderful data. I'm excited by it. I'm a little surprised by it too, to be frank. I didn't think it would do how well it's done. But I would like to see a little longer term data, not so much super centers that do it and then get the result. The other question you could have asked me is, would I put a CRT in that patient? And I don't know if you're allowed to. I have broken that rule. I will tell you there are times that I have made a decision to put a CRT-P in versus just a regular pacemaker. I have yet to do His bundle, but I'm real open-minded on that. That's an intriguing point. I don't know what you guys are doing, but let's say it doesn't hold up. Let's say it fractures. Let's say something happens and the patient goes asystolic and dies, a young patient. I don't think that's something I could live with right now without hardcore long-term data saying I'm doing the right thing.
Yeah, I mean, so I share some of your concerns. I mean, even if you get adequate His bundle capture and your threshold's a little bit higher and you shorten the patient's battery life by 1 or 2 years over the lifetime for a patient, that could mean 1 or 2 additional generator changes, which could mean a higher risk of infection. I think there's a lot of unknowns, but it seems to me it's one of the most important questions we have out there right now.
I think so, but I think what's going to happen, and I've predicted this years ago in a talk I gave to HRS, believe it or not. I had a slide showing a scaffolding from the atrium to the ventricle into which would be connective cells, in other words, conduction system cells. And as soon as the heart now has a new AV pathway, that you would no longer need any pacemaker. Now, I know that may seem, real Star Warsian. I think it'll happen. I think we'll get to a point where that'll happen. I've also seen some things that industry's working on that are fascinating. They're in our future. But you're right, these types of issues require answers. I don't have them, so right now we use clinical judgment. And there's no, I don't think, wrong clinical judgment. If somebody said to me at a meeting that I put in a His bundle pacer in a patient like this, did I do the wrong thing? I would say, I don't know. If you're competent at what you did and you feel it was the right thing and you've narrowed the QRS, maybe you did the right thing, but you better follow closely because we don't have a huge database, right? We're in a kind of a boutique area. Fascinating, but a boutique area. So, but I'm glad you didn't ask me about my personal family. I'm kidding, they're doing fine. My grandkids are good, but anyway, it's wonderful to have another Dookie on the show, and I'm going to get you back. Our next thing we're going to talk about is a passion of yours for years, anticoagulation trials. You've done so many of them, and stay tuned, audience. Next discussion will be on anticoagulation. Thanks for joining us.
Thanks for having me, Eric.